Welcome back to the Canadian Concussion Center's webinar series, which is sponsored by LIUNA, the Laborers International Union of North America. My name is Leslie Rattan. I'm really pleased to continue to be moderating our webinar series, which was developed for individuals that have suffered a concussion, their caregivers, as well as healthcare providers. So if you haven't been with us before, the sessions are recurring every other week on Tuesday evenings from 6 to 7 p.m. And just know as well that all of the sessions that we do are recorded, and you can watch those on from the Canadian Concussion Center website. There's an education section where you can go and see all of our archived presentations. And our sessions generally focus on various aspects of concussion, and we usually have an expert speaker with us presenting for the first half of the session, and then that's followed by you getting your questions answered. So just for this evening, so that you know, if you do have a question for our speaker, please enter that into the Q&A. If you just move your icon, you'll see a Q&A icon at the bottom. So any questions, please enter them there. And if you're having any technical difficulties at all, please enter those into the chat, and Christian can give you a hand. Just before we proceed any further, we just wanted to highlight as well that today's webinar is running on the National Day for Truth and Reconciliation. And so we want to acknowledge the enduring harms caused by residential schools and really honor survivors, their families, and communities. It's also a day, it's an opportunity to reflect on our individual and collective responsibilities in advancing reconciliation. So, as we begin today's webinar, we take a moment to recognize the land we are on and the Indigenous peoples who have cared for it since time immemorial. We encourage all of us to carry this awareness into our learning and our practice. Just before I move any further, we usually run just a quick poll. So I'm just going to ask Christian to pull this up. This is really just to help us get a sense of who is out there watching. I'll just give you a second to fill that out. And so for this evening's session, I'm really pleased to welcome Dr. Carmela Tartaglia back, who's going to be presenting concussion and invisible injury with consequences. Dr. Tartaglia is a professor at the University of Toronto and cognitive behavioral neurologist at the UHN Memory Clinic, where she sees patients with neurodegenerative diseases and persistent symptoms of concussion. She's a scientist at the TAN Center for Research in Neurodegenerative Diseases, where she uses a multimodal approach for biomarker discovery to facilitate early detection of neurodegenerative diseases and diagnosis of persistent symptoms of concussion. She also holds the Marion and Gerald Soloway Chair in Brain Injury and Concussion Research. And with that, I'm going to turn it over to Dr. Tartaglia.
Thank you. I'm going to share my screen. So welcome to everybody. And I will start just, these are my disclosures. So I'm just going to start by providing an overview so that we're clear about what we're talking about. There are different types of brain injuries. So tonight we're going to talk about concussion or mild traumatic brain injury. Sometimes these words are used interchangeably. They aren't exactly the same. I would say concussion is the mild form of mild traumatic brain injury, but usually we think of when we're thinking about assessing them in the emerge, people will, if you go to the emergency room, if after you had a concussion, you might hear somebody talk about a Glasgow coma scale, and that's how we assess people who come in, whether they're unconscious or they've been unconscious. And so you would expect that during a concussion, you would be pretty okay by the time you got to an emergency room. If you had a loss of consciousness, which can happen, it usually is for a short period of time. And if you had post-traumatic amnesia, which is forgetting things before or right after, it would be for less than 24 hours. I have to say that most people it's minutes, or at most a few hours, but not usually even close to 24 hours, but it can be. And that we expect that there be some change in mental status at the time of accident. So sometimes people will tell us they were confused or disoriented at the time, but it's very transient. And this is different than what we call moderate or severe traumatic brain injury. In those cases, there is actually bruising or a contusion, a bruise on the brain, or tearing, laceration, and bleeding. And that's a more severe brain injury. And that won't be the focus of tonight's talk. So concussion is really what we call an acute brain effect. So something happens and that force is felt by the brain. So it can be a blunt impact or a mechanical energy that's applied to the head or the body, and that energy can lead to acceleration, deceleration, or rotational. So when your head turns, and it's important to know that the trauma does not have to be to the head. It can be from a whiplash or it can be from trauma elsewhere on the body. And there can be immediate and temporary alteration of mental functioning due to the trauma. Now, I probably don't need to tell anybody here that these are very common and there's a growing epidemic. Obviously it was first recognized in sports and then the military, but of course, with all the people having falls, especially the elderly in abuse. So there are all kinds of reasons that people can end up with a concussion. And really, we recognized in the last few years that they're very common. And, there was a study that came out of Ontario that basically showed that there's about 150,000 concussions in Ontario per year that interact with the medical establishment. So we don't even know all the, concussions that occur where people get better right away. And so they don't actually go seek medical attention. So we know it's very much underreported. And the other issue with concussion is that it's a clinical diagnosis. That means you need to see a physician, a nurse practitioner, a psychologist. You need to see a medical practitioner that will that can make the diagnosis because there is no test. Although you sometimes hear that, there's a test available, there actually isn't any. And a few times people have promoted some types of tests, but actually these tests have turned out to be much better for more severe injury. So they can, in some cases rule out a more severe brain injury, but they actually can't tell you anything about concussion. The other thing is that, no two people really suffer concussion in the same way. It's very heterogeneous. And so, we often tell our residents, it's like if you've seen one person with concussion, well, you've seen one person with concussion. It's hard to generalize and that's because of all the different symptoms people have. The MRIs that, we often use to diagnose other types of brain diseases aren't really that useful in concussion. They usually look pretty normal. The one caveat I have to say is that now that we are doing more MRIs, we sometimes do see these what we call white matter changes or a little bit of blood, and we don't really know what it means because in the past, and even today, people usually only get a CT scan, and the CT scans are always normal in concussion. So I would say, we don't know the full meaning of this, but right now, the thinking is most of the imaging will be normal if you have a concussion. Why do you end up with symptoms after a concussion? I think the most important thing to remember, it is a brain injury, even if you don't see a piece of the brain missing or bleeding. And some of the symptoms that we end up with that we're going to talk about, I think, come about because of where the injury takes place. So the green part of in the figure of the on the left is part of your brain stem. Okay, it's called the midbrain. And that part has a lot of neurotransmitters, a lot of chemicals that are made that are important for mood, that are important for concentration, for remembering things. So, of course, you could imagine that if there's any disruption, even if it isn't like a permanent disruption, that you may have some changes that are neuropsychiatric or cognitive. As well, the frontal part of your brain, our frontal lobes, our temporal parts of the brain, these are areas that are really important for your personality, for, really defining who you are, your memory. And so those are the areas that are most vulnerable. And that's just because of the way our skulls are made. Our skulls have, the bone, and that bone protects you for the most part. But it does mean that when there's that swooshing of the brain after a concussion, that sometimes those are the areas that are most vulnerable. And so when people get a concussion, they often don't realize that changes in mood, changes in sleep, changes in personality are to be expected, because that's where the concussion um, forces really interact with the brain. So I think it's important to recognize that. So, in terms of the concussion symptoms, as I mentioned, they're very variable. So, lots of people have cognitive symptoms, so thinking problems, slowed processing, difficulty remembering, can't concentrate, personality, mood, big changes there in some of the people. They can get irritable, depressed, anxious, more emotional, trouble with sleep. And then, of course, the physical symptoms also equally important, like headache and tinnitus, and that's that ringing people get in their ears, or to get fuzzy, blurred vision, dizziness, or vertigo, like that spinning sensation, become sensitive to light or noise, a more mild form of headache, balance problems, fatigue, nausea. So you can see there's a whole constellation. Actually, there's, upwards of, more than 80 different symptoms can be found after a concussion. Luckily, most people get better. They're usually within a few days, 10 to 14 in adults, 4 weeks in children, 85 to 90% of people get better. But that's not everybody. When we check neuropsychological function, usually it's back within 5 days. And if they have changes in let's say their neurological system, we don't expect that it's going to be a focal. That means that we don't expect that a person can't move their arm, right? Or can't see, because this is a diffuse problem, this jiggle that goes throughout the brain. But I think, we all recognize that unfortunately, not everybody gets better. And, when you think of 10 to 15%, sometimes, we quote 20%, it's of a lot of people. So 20% of lots of people turns out to be many people not getting better within the 2 weeks that we expect in adults. And so that's really what we think of when we think of persisting or prolonged symptoms of concussion. This is failure of normal clinical recovery. There are some guidelines that used to use 3 months, but now at 1 month, we expect people to be better. It doesn't presume an underlying cause, and we really nowadays focus on the symptoms regardless of the cause. So, like I said, 10% at least. In some studies, 58% did not recover from a mild traumatic brain injury within 3 months. Now that we use the 1 month mark, you could think it's probably higher. And the concept of prolonged or persisting symptoms is actually quite heterogeneous. But it does mean that quite a lot of Ontarians are enduring persisting symptoms. And these persisting symptoms mostly overlap what you saw in the symptoms right after a concussion. So usually we don't develop different types of symptoms. I think the the thing to recognize is when people don't get better, especially within a few weeks, months, we see a lot more of the psychiatric behavioral symptoms, because I think most of us say, okay, I'm going to have a little bit of pain for a few weeks. I can live with that. But then when it turns into months of, constant headache, or, not feeling well, of course people can get depressed. Of course people can get, agitated, anxious, develop some post-traumatic stress disorders, substance abuse. So there's some symptoms that kind of make sense that you see at later stages and not in the acute, first day or weeks. And what I try to tell my patients is that it really becomes a vicious cycle. You've had an injury to the brain, but some of the symptoms you end up with actually make other symptoms worse. So when people have an injury and they end up with, like, let's say a headache, okay, you think, well, a headache, fine. But a headache will obviously impair your cognition because your headache will not allow you to register things as well. It will not allow you to process things as quickly. And so you might feel like, oh, your memory's not as good, your concentration's not as good. Well, that's not going to help anybody's mood. That's not going to help anybody feel that they're, doing well in life. And so then they could get depressed or anxious about that. When am I going to get better? And of course, that will make your sleep worse. That will make your pain worse. That can make your dizziness worse, which will make your cognitive symptoms worse. So it becomes the problem with concussion is there's so many little symptoms, or not even little, they're actually quite substantial symptoms that kind of live together. And so it's so hard for people to, feel like, well, am I getting better? I don't know. That's better, but that's not better. And so we really want to take an approach where we tackle all the symptoms, because we know that if we can help your pain, if we can help your sleep, your headache, your cognition will get better, your mood will get better, that will help your sleep get better. And so, the vicious cycle of concussion is also the cycle of recovery too. So cognitive symptoms, like I've said, very common after a concussion. So patients need to get an assessment. They usually improve within 6 months. Most people improve. And I have to say that most of the time when we do a cognitive assessment, people get 100%. They're always surprised saying, I don't know, like I really don't feel like I'm that good. And I say, yes, of course, because in the real world, you probably, have times where you haven't slept well, you're got a bad headache, you're stressed, you're anxious, and so you're trying to do something, and of course, you're not registering it properly. You can't concentrate, and then you can't remember. And that makes you feel even worse. So we don't expect cognition to get worse over time. We expect it to get better if the other symptoms get help. Now, of course, there could be something else going on that needs to be investigated also, but we do not expect cognitive symptoms in concussion to get worse. Post-traumatic headache, very common. 30 to 90%, I would say it's almost like 100% of people get a headache after a concussion. It's just that luckily most people it gets better right away, but a lot of people end up with headaches. And it's very surprising to me, but there's quite a few people who don't realize that the concussion gave them a headache. And women seem to be more prone to headaches. That's at baseline. Women are more likely to suffer from migraines and other types of headaches. And so, maybe this is why they're more prone to getting headaches. But this is associated with a high degree of disability, even if it's not due to a concussion. Headaches are one of the most, prevalent symptoms on the planet, and they are associated with very high disability. You can have acute, so that's within the first days, you develop this headache, and then it resolved within 3 months. But if it persists after 3 months, it's called a chronic headache. It doesn't actually refer to one specific type of headache once you've had a post-traumatic headache. It can be tension, migraine, usually it's mixed, sensitivity to light in a third of patients, sensitivity to sound, and most of them feel like it's aggravated by physical activities. And then the problem becomes that a lot of patients after a concussion end up on medications like Tylenol, Advil, which can give you medication overuse headache. So we add insult to injury. So, what about neuropsychiatric symptoms? Like I've already mentioned, this is very, very common. And the more concussions you have, the higher risk. And of course, you can have more than one psychiatric disorder. Post-traumatic stress disorder is very common, and those symptoms overlap with other things. People sometimes have substance abuse disorders. They can develop them because they try to self-medicate for pain, for sleep problems, for mood problems. And of course, you could have a well-controlled psychiatric condition that becomes worsened after a concussion. There are actually risk factors for persisting symptoms, and we are using them kind of as red flags to try to identify people that need more help at the onset. So there are medical factors. So of course, if people have had previous head injuries, previous physical limitations, previous neurological, psychiatric problems, if they had a skull fracture, if they have headache at the onset, it seems to be a risk factor. If they're using pain medications already, if they have anxiety, if people have high numbers of symptoms. So people are trying to develop these algorithms to identify people who are at high risk of persisting symptoms. Of course, there are contextual factors. So, if the injury is sustained in a motor vehicle accident, it seems to be worse. There's litigation, unfortunately, is a risk factor for persisting symptoms, not being able to return to work following an injury. Life stressors, of course, one would, could expect that this will make it harder for you to recover. Higher levels of symptom reporting associated with more mood symptoms, older age, lack of social supports. Females have been named in certain studies. Of course, women are more likely to even get concussions. So, this must interact. Um, so why should we care? Because these symptoms are really non-specific, and other factors can affect the concussion symptoms, but also can lead to concussion-like symptoms. So, when people have poor mood, you end up having, your sleep can be bad, but it could also be bad from your concussion. And so, it's hard to parse out, right? Like you're one person. So of course, it's hard for us to say, well, what's due to the concussion versus, something else going on in our lives. I mean, during COVID, it was really tough because people would have had a concussion and then get COVID, and that a lot of the symptoms from COVID overlapped with those of concussion. So we've taken really an approach of let's not focus on the cause as much as trying to fix the symptom, right? Because we don't actually have some change in the brain that we can identify has led to a concussion symptom. And so we treat that. So we treat the symptoms as we do for many things. And so, the symptoms that are secondary to concussion can include the psychological sequelae, the pain, as well as obviously there can be other injuries and the medication side effects. So when we think of a concussion and we think of, the brain, maybe these gears, brains are made up of different networks. And so when we think of these things, then we think, if one of the gears stops because of the concussion, it can actually affect all the other gears. All the other networks can be affected. And so sometimes just by helping one of the networks get better, that we can actually, kind of rev up the system so that there can be improvement. And I have to say, most of the patients improved. The only reason we can have clinics and see new patients is because we get to discharge many patients because they do get better. So we treat the symptoms. There are many treatments for the different symptoms that patients have after a concussion. Mood symptoms are very common. We treat with either, it could be goal management therapy, cognitive behavioral therapy, antidepressants, anti-anxiety, many different medications for headache prevention. There's actually some new ones now that have, been promoted as almost miraculous, and having a few friends with migraines for lifelong migraines really can vouch for that. Sleep apnea, very common in our society, and there is treatment for that. Balance problems, so we really take low impact exercise. Actually, I don't want to forget that one because that's super important. There's lots of evidence that helps people get back to their lives, modified return to work, school, or play. So it's really important to treat symptoms so people can get back to their life as much as possible. Now, in the last few years, people have recognized that concussion or mild traumatic brain injury can be a risk factor for dementia. There have been So everybody already knew that a moderate or severe brain injury, increased your risk. But it's now been shown that even one mild traumatic brain injury can increase your risk of dementia. Now, I have to say that I actually don't think anybody has not had at least one concussion in their life. When we learn to walk, many of us fall repeatedly. And and then we cry and we have, our parents don't know what's happened, and sometimes you'll hear parents say, they were really fussy for a few days, but they're all better now. So there are probably way more concussions than we actually know about. But it has been recognized that, repetitive head impacts are not good, and that we should be, wary of them and obviously trying to avoid them as much as possible. And so, what does that really mean? So, a few years ago, and this was updated, 14 dementia risk factors have been identified. So, this is when you put all the data together from millions of people, in different areas, and you say, okay, what are the things that are, most associated with dementia? Well, head injury made it to that list. But I think it's always important to note what else is on that list. Because if you've had a concussion, you can't actually change that. That's already happened. But that means that maybe you need to focus on all the other risk factors here, because those things you actually can change. So physical inactivity has been named one of the top risk factors for dementia. Well, we can change the amount of physical activity that we do. Smoking is another important risk factor. Excessive alcohol consumption, and you have to remember the new guidelines are 2 alcoholic beverages per week maximum. Actually, it was 0, but the Canadian guidelines allow 2 now. Air pollution, social isolation, lower education, and I don't mean just school. Lower education means not engaging in active learning throughout all of our lives. High blood pressure, diabetes, cholesterol, vision loss, hearing impairment that isn't. So there are a lot of risk factors on this list. And, if you have one that's already happened, I always stress that what the importance is to actually engage in some of the other activities that will mitigate that risk. So if you had the concussion, then I think you really need to, think about that healthy brain health basket and fill it up. Fill it up with physical activity to counter the head injury you've had. Eliminate alcohol consumption, stop smoking, be active, learn, make sure your vascular risk factors like high blood pressure is controlled. So there are lots of things that we can do even if we've had a concussion. The other thing people worry about, and this has mostly only been described in the athletes, is chronic traumatic encephalopathy. This is what always makes it into the news, a progressive neurodegenerative disease that was triggered by repetitive mild traumatic brain injury. I think now we think it's actually mild repetitive head injuries. So these subconcussive blows. It was described first in boxers, but now recognized in hockey, football, military, recently the homeless. And in the general population, this is very, very low. It's like 0 to 2.2%. But recently, somebody from our group showed that in the homeless, it's about 12%. This was one of the studies that showed that having a mild traumatic brain injury, even 25 years before, increased your risk of dementia. So this was out of Manitoba using these administrative databases. This was a retrospective population case controlled study. And they showed that dementia was elevated. They showed an elevation for Parkinson's disease. And also they looked at attention deficit disorder and mood and anxiety. So, of course, we do think that sustaining a concussion, a mild traumatic brain injury, is not something that needs to be ignored. It needs to be considered. And, like I said, it becomes even more important to do things to counter that risk, because you can't change the past, but you can definitely change the future. These are just data to show that, over the years, people have really accumulated a good amount of data that there's an increased risk of Alzheimer's disease when there's been mild traumatic brain injury. The same thing for Lewy body disease. I don't know if people have heard of, Robin Williams and his disease, but traumatic brain injury has been associated with an increased risk of that. And the other one is ALS, or motor neuron disease. This is also known as Lou Gehrig's disease. And again, people have showed that, mild traumatic brain injury, concussion, this repetitive head injury, was associated with increased risk. And so, like I said, you know, if you've played sports that had repetitive head injuries, if you've had concussions, there are still many things that you can do to counter that risk. And so I think it is really important to do that. So to summarize, concussions are the result of brain trauma. I think it's important to recognize that. There are a very number of symptoms, but they come from the brain. And so people will complain of memory problems, headache, dizziness, sleep issues, psychiatric issues, and that persisting symptoms can occur. Luckily, most people get better, but 10, 15, 20% of hundreds of thousands of people is going to, result in a lot of people having persisting symptoms. And that even one concussion, one mild traumatic brain injury, has been implicated in a number of neurodegenerative diseases, not just CTE, but Alzheimer's, Parkinson's, FTD, ALS. But there are mitigating risk factors that you can uh, focus on, so that you can counter the effect of the concussions that have already occurred. And thank you. We'll stop sharing.
Great. Thank you so much, Dr. Tortelli. That was excellent. We do have a number of questions. So if any of you have questions, just a reminder to please enter those into the Q&A. We have someone asking, so I guess if someone has to have an MRI and they're severely claustrophobic, they're wondering, is it possible to be asleep when you have your MRI?
Yeah, so one of the things we can give to people is, we don't usually do general anesthesia, like put you completely asleep. But what we do is we can give people a sedative like Ativan. So that is a short acting benzodiazepine. So usually people would take it like an hour, half an hour before the MRI, and it would probably keep you asleep for the 30, 40 minutes of the MRI. And then afterwards, you'd be a little groggy, but you would be okay. If we give you one of those, we would ask that you come with somebody, because you might be a little unsteady. You might not feel great afterwards, but usually it's short lived, and people walk away. So we do that quite often.
Great, thank you. The next person is asking, what do you think of the latest trend of health providers who promote their capacity to determine the type of concussion? So, so for example, concussions coming from the neck versus something else, and then they're recommending specific treatments based on those respective types of concussion.
Yeah, since I don't do that, I really would not be able to comment. I'm not really sure how you do that. The fact is that I think it's important to recognize whether you've had a whiplash injury. So, of course, if you had
Hmm.
neck injury on top of the concussion, both of these things need to be addressed, and they need to be addressed separately. So, I think that's important, but I don't really know how you would. To this day, we don't have a biomarker for concussion. It's a clinical thing. You tell us that something has happened, and after this event you feel differently, which is a problem for, like, let's say, older people who have some cognitive impairment and may even not be able to remember that this has happened to you, that this has happened to them. But really, we don't have a good like a sign, not a sign, but like a biomarker, like a biological test. So I don't know how you can really differentiate, but maybe they
Hmm.
have ways.
Okay, thank you. Um, Small vessel ischemic disease has been discovered since the concussion. So it sounds like someone has had that diagnosed since their concussion. What or who is the best specialist to manage that?
So small vessel disease is basically, so I'm assuming you had an MRI. although we can see a little bit on CT scan, but an MRI is the best thing for that. And what we see is these white matter changes on the MRI, and we attribute them to small vessel disease. Small vessel disease is what we call a vascular risk factor. It is usually due to high blood pressure, cholesterol, diabetes, smoking, can be from alcohol, can be from, and this could have happened long ago. Once this happens, and it changes the brain, that image will remain like that forever. So I think the most important person who, first of all, you have to see what to what extent, and secondly, it's mostly, unless you've had a stroke, it's mostly the family doctors who deal with those vascular risk factors, making sure your blood pressure is well and things like that. So, if you had a stroke, you go to stroke prevention clinics. But otherwise, usually the family doctors are really good at managing those vascular risk factors.
Great, thank you. Someone else is asking, which cognitive test are you referring to when you say that people usually score 100%? Also, if cognitive issues persist for more than 2 years, should one get a full neuropsychological assessment?
Yeah, so the cognitive tests can be very various. I mean, the ones we use in our clinic, in our studies are, they're varied. So sometimes we do a MOCA, which is a short test. Sometimes we do this TORCA, which is a, 45-minute, more comprehensive test. Neuropsych assessments, for the most part, are not covered by OHIP, so we can't get them routinely for our patients. We do some in our we have a program for former professional athletes, and we do a lot of neuropsych testing there. And that's like, I don't know, Leslie, do you do them in those? I think it's like 4 hours of testing.
Yeah, it's a comprehensive assessment, many
It's a
hours. Yeah,
very, very comprehensive. And so, yes, we use different types of tests. And luckily, most of the time, our patients do quite well. They don't have, of course, anybody can get a concussion. So we have patients who have some kind of cognitive impairment, not necessarily from the concussion, but from some other disease. Some of them have Alzheimer's, some of them have Parkinson's. And so we do find, but most of the 20, 30, 40, 50-year olds that we see and we test them, we don't find significant cognitive impairment in them.
great. Thank you. This is more of a comment, and it's interesting because it made me think of Dr. Tatter. We've got someone commenting, we really need to move away from using the term mild. That
Yeah.
really is only an acute diagnosis to signal no anatomic disruption. It's a TBI, as in a traumatic brain injury. To use it beyond the acute phase is disingenuous, particularly if the symptoms and dysfunction is prolonged.
Yeah, so maybe you have heard Dr. Tatter. He thinks that we shouldn't use the word mild because the point is that it kind of alludes to it being more benign than it is. The issue is that we have to speak the language of everybody, and right now even the most recent diagnostic criteria include that term of mild traumatic brain injury. We do have to differentiate it from moderate or severe traumatic brain injury, because otherwise there would be confusion. If you look at if somebody dies at a concussion stage, or not from the concussion, but let's say a heart attack, and somebody of a moderate traumatic brain injury dies and they also have from a heart attack, those brains look completely different. So we have to be precise about what we're talking about. So I agree, not mild in the sense of the brain of from a brain, from a cognitive neurologist perspective, anything that affects the brain is not mild. It affects your brain. Your brain is who you are. And anytime your brain changes, you change. So the brain deserves that respect. But because of, I guess, traditionally, historically, it's been called a mild traumatic brain injury. We've kept the term.
Hmm. Hmm. Yeah. Yeah, and Paul has commented, mild may not be a great term, but the term brain injury is important to understand that in fact is what a concussion is. So,
Yes,
yeah.
exactly.
Yeah. I'm in the seventh year of post-concussion daily headaches. I've used various forms of medication, visual therapy, etc. Still have them, including pressure and particularly screen sensitivity. Is there anything else to try?
Yeah, I don't know. I mean, it's really tough. Like headaches are really hard. And there are the new medications. I don't know if you have been assessed by a headache specialist recently. There's a whole new family of medications that came out. And for some people, it's been life-changing. Obviously, not for everybody. So I would say if you haven't been assessed in the last 2 to 3 years, you haven't tried any of these GPANs, they're calcitonin receptor antibody mediated medications. I would see a headache specialist about that.
Hmm. And just flagging our next talk in 2 weeks, we have Dr. Claire Sando, and she's going to be talking specifically about headaches. So you may want to tune into that.
Yeah.
Uh, Next question is are post-concussion symptoms a risk factor for long COVID? So
No,
I guess this would
I,
be
yeah, when we think of risk factors, we think of very specific things. I think one of the issues, so I used to see people with long COVID. And the reason actually that I started seeing them is because in discussing with my colleagues who were seeing the COVID patients, they were describing post-COVID symptoms that really overlapped with post-concussion symptoms. So I said, maybe I could help some of these people by using the same treatments, and actually a lot of it worked. So I don't know that it sets you up. But the thing is, if you have persisting symptoms from one thing, and then you get, this new disease, this new problem like COVID, and you already had those symptoms, and the consequence of this new disease is almost identical, then at some point you can't tell what is the cause, right? They just persist. So I think it's very hard, but I don't know that it's the fact that it was from concussion. I think the fact is that they were persisting symptoms that set you up for more prolonged symptoms afterwards. It's the same thing we see when people have, they had a concussion a few years ago, they didn't quite recover, they had a few persisting symptoms, they get a new concussion, they get some new symptoms, and then that one symptom that they had before, they can't tell. Is it much worse? Is it the same as before? So I think it's hard because we're one person and things are happening to us. So I don't think it's a risk factor except for the fact that you have something before, which, when I was talking about those contextual symptoms, those contextual factors and the, biological factors, those are what sets, let's say, puts you at higher risk.
mhm. Okay, thank you. I think we have a pickleball player who's asking this question. What is your opinion of the risks of pickleball for head injuries?
I actually encourage a lot of my patients to play. I think sports are really good, but
Mhm,
I've seen people get concussions from synchronized swimming, from doing activities that I didn't really think. So yes, I
mhm,
mean all activities you are at risk, but I think for the most part we think the benefit outweigh the risks.
mhm, mhm. Okay, thank you. Is it worth having an MRI at 10 months post-concussion if you're still having symptoms?
Yeah, I think it's not about the fact that you have persisting symptoms. It really sometimes depends what the symptoms are. We don't have a cutoff time. When 15 years ago, everybody I saw, I would do an MRI. But then after hundreds of MRIs and never finding anything, now my threshold for doing an MRI is quite different. So I only do it if, like, let's say somebody has kind of odd symptoms, or let's say localizable symptoms. I'm really worried because I do a cognitive assessment and something, they come out abnormal, and I don't know, I can't explain it just from the concussion. So I look for reasons to do the MRI above and beyond just a simple concussion. So I think for the most part, we don't MRI people after concussion so often anymore.
Mhm. Okay. Concussion, can concussion raise your blood pressure?
Yeah, that's a great question. So the issue is that I'm not certain. It's not like we think concussion, there's a pathophysiology of how concussion raises your blood pressure. But the problem is some of the symptoms of concussion. So let's say you have a headache or you have pain. Well, pain raises your blood pressure. Let's say you have anxiety. Anxiety raises your blood pressure. So it's not to say that your concussion itself is raising your blood pressure, but definitely some of the symptoms that come about because of concussion can raise your blood pressure. Not sleeping well, which is a very common symptom after concussion, can increase your blood pressure. So that's why we say we really take an approach of we try to target as many symptoms as we can early on to try to avoid these secondary problems because high blood pressure is bad for your brain, bad for everything,
Mhm.
but it's really bad
Mhm.
for your brain.
Yeah. Great. Thank you. Heather is asking, when people have a concussion, is there typically also a neck injury?
Yeah, that's a great question. And, in it's not always, but in many cases, yes, right? Because you think of how, motor vehicle accidents, very common cause of concussion. And you can imagine your neck moves, right? So people often can end up with whiplash. A fall, right? Fast movement can end up with neck. So we have to always assess the neck because there can be many cases where the neck is involved. And if you ignore, I was talking to somebody today, an older gentleman, and he was complaining that people had focused on his arm. He was focused on his brain because he was worried he'd had a motor vehicle accident, but they were worried because he broke his wrist. And he thought, nobody asked me about my brain. And I was always worried about that. So the problem is we tend to just focus on one thing and forget that the whole person is there. That's not going to
Mhm.
help anybody.
Mhm.
So I agree with you. We should focus on the neck and the head because they're very closely attached, and you don't want to miss it. Um, there are instances where I've heard people say, "No, I didn't get any neck problem from it," but we always ask people.
Okay. Great. Thank you. Um, Next question. So, someone has returned to work after 2 years off due to a concussion from a car accident. They've been working from home and just barely managing symptoms. They're now being pressured to return to the office 3 days a week. They're asking, how do I explain to my employer the endless limitations I have resulting from the concussion? How can they accommodate the irritability, the commute, the overstimulation? And they're just finding it understandably to be a lot.
Yeah. No, that's a great question. So I think, firstly, we would want you to go back to your pre-injury work. So if that means in person, that's what we want people to work towards. Usually, and if you're saying irritability and stuff like that, I would hope that there be some treatments of that irritability so that you're not, struggling with that. What we usually want is say, okay, if you're doing it at work, at home, then maybe you would go back not to 3 days, maybe you go back, one day, especially if you're saying, some people it's no problem. We just say, okay, 3 half days, try that, but not everybody's work is amenable to the same things. But if you're saying, well, I'm barely managing a full work week at home, then maybe you go back to 1 half day a week for a few months, or a few weeks, depending on how you feel. And if you're saying, well, I have sensitivity to light and sound, well, I would hope that that's being treated. So you shouldn't be having that anymore, and you're on some headache prophylaxis, and so that you that's diminishing. Because if you're 2 years out and you're still having those symptoms, I just wonder what therapy you've been given because we are seeing sometimes people who aren't actually on the appropriate treatments. If you have sensitivity to computer screens at 2 years out, then I think we need to change your therapy.
Mhm. Great. Thank you. Meg is asking, does it take longer to recover from a mild concussion if you are older or elderly? She said, I'm 80 and I'm 2.5 years along.
Yeah, I think that's a great question. And, it actually is an area of research for us because you may or may not know, elderly people were largely excluded from many studies. So we actually don't have very good data on them. What we do know from more severe injuries is that older people have the same potential to recover, but it can be a little bit slower, yes. But we also sometimes see, so in my clinic a few years ago, I had checked how many people over the age of 65 I was getting referred, and it was less than 1%. Now, over the years, in the last 2, 3 years, we've seen that number going up, but still, it's nowhere near what it should be. So, and I also see that sometimes when the older people are coming, they haven't been started on any therapies. So to say that a person has prolonged symptoms, but they aren't being treated for any of those symptoms, is almost an oxymoron. You need to be treated to say, okay, I failed those treatments, and that's why I have prolonged symptoms. But if you're not given any treatments, and I know that sometimes with older people, we are more worried, we are more cautious. Maybe let's wait a little while longer, let's let you get better on your own. But at some point, I would be intervening and saying, yes, there needs to be treatment, active treatment, and some of it is medication, some of it is exercise, whatever it is.
Hmm.
And then let's see, if you truly are a prolonged symptom, or it's just, you haven't been treated for the symptoms that you have.
Hmm. Great, thank you. Can challenges with word finding come after concussion?
Yeah, I think people do. So word finding difficulties. So is a cognitive change. So yes, people can complain of word finding difficulty, and then it could come about because of the concussion. It can come about because people get anxious. And if you get anxious, anybody who's anxious will tell you they can't find a word, even their name. So there are many reasons that people complain about word finding difficulty after a concussion. Don't sleep well. They have headaches. They're dizzy. They, feel like their vision isn't very good. All those things will make you not feel well. Sometimes people have persisting symptoms and then something else happens. Like, we have, I see sometimes females who have had a concussion, let's say, 1 to 2 years ago, they have persisting symptoms. But in the last 6 months, they've become perimenopausal. Perimenopause is associated with word finding difficulty. So, of course, being one person, they have no clue where the symptom is coming from. They just feel like, wow, my word finding is much worse. I don't know what's going on. Maybe it's because I got concussed and it didn't get better. And then you ask a few questions and you realize, well, I don't know. I think it's just all that stuff that's happening to you. Um, aging aging is associated with word finding problems. It is the only thing we accept from the aging brain. Aging does not cause you to have significant cognitive impairment, but we do see that people's fluency goes down with age. So I don't know how that interacts for you, but yes, after a concussion, we do hear people complaining about word finding difficulty.
Great, thank you. What can be done treatment wise, excuse me, for someone with persistent symptoms that is having sensitivity to light and sound, including extreme fatigue after doing too much activity?
Yeah. So sensitivity to light and sound is kind of, think of it like a headache. It is in the headache family. It's just that, you're maybe lucky you don't get as much pain, but you still are sensitive to things that you know, weren't before. So people who have headaches outside of concussion will tell you that often they have what we call photophobia and phonophobia. It's very common in migraine. It's actually, we use that to make the diagnosis, and that is sensitivity to light and noise. So I treat it like headache. And I use headache prophylaxis medicine to try to prevent that. And so over time, we build up people's tolerance. And so they can go back to, being in bright rooms and noisy environments, which is, honestly part of life. We don't want people wearing sunglasses and headphones and living their lives in quiet spaces. That isn't, life unless it is your life. But, most of us are, unfortunately, we're in noisy environments. So I think it's important to get ourselves back to that. And so we treat it like headache prophylaxis with headache prophylaxis medication, which means headache prevention medication. And we manage to usually get people back to their pre injury baselines.
Great, thank you. And there's a couple more questions, just it's obviously very common, just sensitivity to screens and just flagging as well that Dr. Tatter has actually done a specific talk on that that you can access on the Canadian Concussion Center website. Um, Jill is asking, Dr. Tatter talked about the brain remembering, and that was a reason why a second concussion is always worse than a first. Could you please explain what the biology is of this brain sensitivity so that a person is more susceptible after each consecutive concussion?
So, in terms of what the pathophysiology, so that's what happens to the brain. There are many different theories, and we don't actually know. So, people talk about oxidative stress, one thing. People talk about energy metabolism changes. People talk about inflammation. People talk about all kinds of things, and we don't actually know what it is that happens in a concussion that really sets you up to have all these other symptoms. But what has been recognized is that, and this is kind of routine and classic. It happened, we see it all the time. When a person has a concussion, it's like the, let's say it was a certain force that had to be exerted to the brain to get that concussion. We see that when people complain about a concussion, at the second, third, fourth, it's like less force is required. So sometimes people will say, and you see it also with like some of the sports, the athletes will tell you, it's like, oh yeah, I got, the first time this happened to me, somebody checked me into the boards and I fell on the ice and I was out and, I had a headache for, a few months. And then the second time, I fell on my bum and I had a headache for 6 7 months. And then the third time it was like I hit my head on the cupboard, not hard at all. And the symptoms, and it's hard to know, is that really always the same thing happening to the brain, or is it that you've become more sensitive? So think of, if you hurt a part of your, you twist an ankle, and then, or you break your ankle, and then that ankle, even when you're back to normal, it's always a little more sensitive. It's almost that, your brain doesn't recover if there's a second concussion. Now, I'm not talking about, sometimes, 20 years goes by. I don't think that has,
Mhm.
oftentimes we don't know, people don't tell us that, oh, it took a smaller, like a smaller hit. But if they happen in, within a few years that you're just getting more of them, I think, and less force, we do hear that a lot, but it's not that we understand what has happened to the brain to change that. We don't expect that the brain remain inflamed for months and months and months, but maybe there's a low level, could be. I think this is areas of research, not that we know exactly, oh, yes, this is what happens to the brain after a concussion. So this is what we're going to look for.
Mhm.
Yeah.
Okay, that's great. Thank you very much. I'm just conscious of the time, and we've got so many great questions, but I think we'll just have to do one more. Do you have any information concerning seizures after concussion? So I guess wondering how frequently does that happen?
Yeah, so I have to say that we don't see that very often. We have, I actually have seen, I've heard a few, mostly from athletes falling on the ice. I've seen some,
Mm,
um, but I see more often patients who end up with a concussion because they have a seizure disorder, and they had a seizure and they hit their head. It isn't that common, but it can happen because no matter what, if you hit your head hard enough, uh, the brain can be hurt and that can lead to a seizure. It's just, the amount, like I would say that that's a much more severe injury if you end up with a seizure after a concussion. Now, that being said, if everybody can get a seizure, if let's say we don't sleep, we drink alcohol, we stop drinking alcohol. So, of course, if that hit to the head happens already on a background of somebody being in a kind of like optimal state to get a seizure, that's a bit different. But seizures after concussions are actually quite rare.
Mhm. Great. Okay. Thank you so much, Dr. Tartaglia. That was excellent. And thank you, everyone, for the great questions. I'm sorry we couldn't get to all of them. But do keep your eye open. There's going to be a survey that comes out. It just takes a minute or two to complete, and you can provide any feedback. If you have a question that didn't get answered, you can enter it there. Just know that these are anonymous. So in order for anyone to reach out to you, you'd have to leave us your contact, your email as well. And just also a reminder that for those of you, that are dealing with headaches, we've got Dr. Claire Sando in 2 weeks. So thanks again for watching tonight. And thanks again, Dr. Tartaglia. That was excellent.